your favorite midwife, Christine, here with the Birth Exchange podcast again. Whew, I'm so glad to have this episode because I am with my dear friend, Dr. Hedwig St. Louis, who is a board certified physician here in Atlanta, Georgia, serving the women in Atlanta. And I wanted to bring you on, Dr. Dee. Can I call you Dr. Dee?
Please do.
Dr. Dee, I'm so glad you're with us today because I feel like we can have a very healthy conversation
Hmm.
about the issues and topics going on in the birth community,
Absolutely.
between
Absolutely.
midwife, between doctor, and just on a professional level, just bringing some, I don't know, alliance,
Yes.
right?
Yes. Yes. Yes.
That's the
Yes.
word.
Absolutely.
When we talk about the different issues that we're dealing with.
Hmm.
hmm And we both have our own experiences
Absolutely.
in caring for women. And I just wanted to be able to share with people on this platform.
Absolutely.
So, can you please just introduce yourself and tell us who you are and where you are?
Who am I? Where am I? So I'm a OBGYN in Atlanta. My name is Hedwig St. Louis, but I go by Dee Dee St. Louis. My patients call me Dr. Dee Dee.
Mm.
My daughter, when she was 3, had this little thing where she's like, call Dr. Dee Dee if you want to have a play date with me. So they kind of just stuck.
Beautiful.
I've been at OBGYNs, for 20 years now.
Mm.
And I've been in Atlanta for 17 years. Yeah, 17 years this year. And I've done a little bit of everything. I was in private practice, absolutely love private practice, but it wasn't my calling.
Okay.
So I enjoyed my patients. Some of my patients became my friends, but
Mm-hmm.
it just wasn't my calling to be in the private office. And so I went to Morehouse where I've been teaching at Morehouse since 2010, roughly.
Mm-hmm.
I've also worked with Planned Parenthood, did a lot of legislative stuff, really learn about what's going on in the Southeast outside of just obstetrics.
Sure.
In one of your episodes, you were talking about women's health care just as a whole, not just focusing on obstetrics. And so,
Sure.
working at Planned Parenthood gave me a chance to really hear what women outside of metropolitan cities, what they're going through, and some of the prejudices or racism, violence, whatever word you want to
Mm-hmm.
put on that, but the way that they're being treated outside of the metropolitan
Mm-hmm.
areas of the South. And then I left Planned Parenthood and I became an OB hospitalist. And I
Mm.
think I finally found my calling.
Mm.
So OB hospital is essentially what we are, our obstetrician that strictly care for women in the hospital. We do not have offices. We don't provide office services.
Mm-hmm.
We are sort of the backup physician so
Sure.
that women who come to labor in the hospital, if their provider is not able to make it or if their provider is busy with another emergency, we're there to make sure that these women are safe, that
Mm-hmm.
they're laboring in a safe environment. At least that is the purpose of being a hospitalist, to provide a safety net for women who are coming to the hospital. And so I've been doing it since 2019. I was at AMC before AMC closed and really, really enjoyed working in that community, really
Mm-hmm.
learned a lot about the things that we don't talk about in the OB community, not just focusing on some of the experiences that women do discuss, but really talking about homelessness in obstetrics,
Mm-hmm.
talking about patients who are illegally here
Mm-hmm.
and who are pregnant. I think we often talk about a lot of the populations that we're more familiar with, but we don't talk about those women who are really on the fringe, who are either homeless, have mental health issues, are illegally here, may
Mm.
not speak English properly. And so it gave me a chance to really work with that patient population. And I learned a lot. There's a lot that we're
Mm.
missing.
So
Even those of us
much.
who are actively out there, we're missing so much.
Mm-hmm.
So
I love that you said being an OB hospitalist is your calling. I don't think I've ever heard a physician say that. You know why? Because you're on the front lines of
hmm
whatever walks into the hospital.
yep.
And so you are the physician responsible on call to take care of anything that comes to you
hmm
and at you. So that's a very, I'm sure, very stressful role to be in. But what I hear you saying is that you get to kind of uh, touch people's lives in different ways.
It
Like,
does. And I think what I've learned being a hospitalist is to really walk in a room with no preconceived notions,
mm,
right? I think when we're in private practice, you have that little model of,
yes,
who you're going to work with,
definitely.
who your patients are.
Mm-hmm.
Um, when you're in the reproductive justice activism,
Sure.
you and I cross path all the time. Like there's
Mm-hmm.
that little population that we're addressing
Yes.
and that we're
Yes.
helping to vocalize what their needs are. And then there's that population that nobody really talks about, right? The
Mm.
patient who has mental health issues and doesn't want to be pregnant, who, you know, nobody wants to make the decisions for her, but they don't want to allow her to make decisions for herself.
Mm.
Or that pregnant person who comes in and says, I don't want to take my medication because I'm concerned about what it's going to do to my baby. And how do we
Mm-hmm.
how do we empower that person in their mental health and also empower them in their obstetric health?
Without judgment.
Exactly.
So you're kind of a unicorn.
Sort of, kind of, yeah.
Well, I'm telling you, you are. That's why I invited you here, because you're probably one of the most compassionate, respectful physicians here that I've ever met in Georgia, and that our moms really speak highly of you when they encounter you at the hospital. Now, what people don't know is that Dr. Didi is an ally. She is a home birth ally only because you're just so very respectful. And I probably shouldn't say it, but I do text you sometimes like, Dr. Didi, are you on call? Because we're in home birth and we need to transfer in and I want to take them here where you are at. But it's just such a blessing to be able to, just have a relationship.
Mm-hmm. Absolutely.
You know?
Absolutely. And I think we have such a long way to go because we don't know how to talk to each other um, in within each of our little silos. And I think because we're in each of these little silos, we hurt the people that we want to care for more than we
Wow,
care
that's the
for
word. Yeah.
them. Again, one of the episodes for your podcast, one of the guests was talking about having a multidisciplinary team. Right?
Mm-hmm.
And I felt like from my personal experience, the best care that I got was when I was pregnant with my second child. I had my perinatologist because I was old and fat. I had my obstetrician because I had had a previous C-section. And then I had a midwife because
Mm-hmm.
I needed someone who would give me the space to be hormonal
Sure.
and help me navigate these parts of becoming a mom a second time and all these other things that are going on. So I had all these different people, but I knew they each played a role, and
Yeah.
that allowed me to just focus on just being pregnant, which was nice, not to have to worry about, you know, if I go to my OB and I say I'm feeling this way, is am I going to have the space to discuss this, or all those different questions that come up when you're pregnant. So
And I feel like that's ideal
to
for
me, it
every
is.
woman to have a professional who is specifically for a certain aspect of care,
Absolutely.
especially during pregnancy. And I
Absolutely.
feel like that is just not existing. That is
It's hard
almost
to create.
non-existent. Um, and how can I say this? Like, it's definitely non-existent in the home birth space,
Absolutely.
right?
You guys have it hardest.
We
yes.
have it hardest. They hardly talk to us.
You
Okay,
have it
like
hardest.
the clients, if they say anything about home birth, they're getting fired from their providers. And then they're just kind of left out here to fend for themselves, and we're kind of trying to help them, when something goes awry, right?
Mhm.
So it's very unfortunate. So
It
can you
is.
tell me why is it like that? What is it about home birth that's so horrific to physicians? Why is it so bad?
um
And I understand the things. I just want to bring the conversation to like the light.
Absolutely. And I
Mhm.
think part of what I've enjoyed with you is that because we have a relationship outside of the work
Yes.
relationship. So
Mhm.
I think it fostered the trust.
Correct.
And you've allowed me to ask questions that other people would be like, "Why are you asking this? You're questioning me." When
Sure.
I wasn't questioning you. I was questioning the moment, right? Like,
Mm-hmm.
how did you, as a professional, as a home birth midwife, how did you navigate this particular
Sure.
moment? Because I know
Mm-hmm.
me as an OB, I would see this and I'd be like, "Oh, I don't know how am I going to handle this,"
Right.
right? Um, and as we were as we've talked before, I think part of the issue is we don't talk to each other until after we've graduated.
Mm.
And so we don't really know, I don't really know what you do. And so there's all this mystery about you're at home and you're doing these things that are not necessarily what would be done in a hospital
Sure.
setting. So a
Uh-huh.
lot of it is ignorance, right?
Mm.
Some of it is lack of communication, not
Sure.
being able to really communicate, like really listen to what the person is saying.
Mm-hmm.
And then, I mean, I hate to say it, some of it is also lack of respect,
Yeah.
right? The respecting your knowledge in your field, that there are things that you know how to do better than me, and
Mm-hmm.
then
And
there are
vice
things that
versa.
I know how to do better than you. So how do we meet each other so that our patients can have the best of both,
Mm-hmm.
right?
Right.
And then there's also, when you look at the history of obstetrics, we have this really unfortunate
Foundation.
history. Our
Mm.
foundation is so
Mm.
it's rooted in racism.
Mm-hmm.
It's
Mm-hmm.
rooted in slavery. It's rooted in colonialism. If you're
Yes.
looking outside of the United States, and when you really think about the history of midwifery, it's almost as if they stamped out black midwives or granny midwives
Mm-hmm.
or the women at in French it's called femme sage, like a wise woman is what a midwife is. It's a wise woman.
Mm-hmm.
And it's almost like they stamped all of those and then they sort of put it into a box,
Yeah.
and then you have all our my white colleagues, not to cast anything on them, but that's the history
That's
of
the
where
history.
we are, right?
Mm-hmm. Which we can't deny.
Exactly. And so I think when you put all of that together, there is so much midwifery, home birth especially, has been vilified,
Absolutely.
right? And so how do you clear that up, not just between the physicians and the midwives, but also between the midwives, right? How do you counsel patients so that they know what they need to do to have the best situation for themselves,
Got it.
right?
Mm-hmm.
Because just because you go to a midwife doesn't mean that everything's going to be great.
Mm-hmm.
And
Correct.
just because you go to a physician doesn't mean everything's going to
Correct.
be great. So
Mm-hmm.
where is that happy medium where maybe you are the perfect candidate for a midwife, but if something goes wrong, that midwife has a great relationship with a physician and she can call the physician and say, "Hey,
Right.
this person really is not in the right spot. Can we transition her care?"
Mm-hmm.
And then she can pick up where you are. And a lot of those relationships that you and I have, I think, are born out of trust and being able to be candid with each other and not being afraid of difficult questions
Sure.
and not taking things personally and just really putting it where it is, which is just a conversation, you
Right.
know.
I love what you said about the history
Hmm.
because we can't be mad at women, black women, who are just not feeling safe in different spaces, right?
Absolutely.
And so even that truth drives decisions for
Absolutely.
their care that may not be as ideal
Hmm.
and not be probably the safest situation for them. But out of I'm not going to walk into this space because this is abusive.
Hmm.
I'm going to do this.
Hmm.
Those women are highly judged, right?
Absolutely.
When they are having to face a medical professional, it's like so many things that they are already labeling her as
Hmm.
because of, and no one thinks of the foundation and the root of everything.
Absolutely. Absolutely. Um, it's hard.
Yeah.
I think it's very hard. I know for myself, one of the things that I've been very um, that passionate about over the past few years is how
Mm-hmm.
we train upcoming physicians, right? I have friends who are really focused on the system,
Mm-hmm.
like Dr. Karen Scott. They're
Yes.
like really focused on the system. How do we change the system? Um,
Mm.
and I always say I try to complement what she does because I'm focused on the people in the system.
Mm-hmm.
Because if you change the system but you don't change the people, I strongly feel the system will reset right where it was.
Agreed.
And so, really thinking, just like you said, how do we how do we train our up and coming professionals to speak to one another, whether they're nurse midwife students or medical students? How do we
Mm-hmm.
teach healthcare professionals to speak to people? Because, I've seen midwives who are amazing.
And
I've
some who
trained with
aren't.
midwives who, I was so fortunate as a resident to train
Sure.
with midwives who are
Mm-hmm.
just, I learned so much from working with them. And then
Mm-hmm.
I've seen midwives who are like, okay, that's not how Christine does it, but I'm going to just sit here in the corner and
Just
just
sketchy.
watch it.
Yeah,
Okay,
yeah, yeah.
sure.
Mm-hmm.
And I think we have a long way to go.
Yeah.
There's so much that we need to change in how we train our upcoming healthcare professional. And it really starts with acknowledging where we come from. I know OBGYNs, we have a long way towards acknowledging that. But I was reading a piece about the history of midwifery, and it sounds like there's similar internal, what's the word?
Just
Um,
deconstruction.
yes, that needs to occur in every part
Mm-hmm.
of healthcare, not just MD, but RN, CNM,
Sure.
PA, et cetera, et
Mm-hmm.
cetera.
Mm-hmm.
Um, but the burden is on us.
Mm.
I really feel that the burden's on us on how to change things and how to learn to work together and stop um, the distrust, mistrust that
Mm-hmm.
exists between physicians and midwife, whether they're birth center midwives or home birth midwives.
Yeah.
I think hospital-based midwife we work well with,
Right.
um,
Well,
but
the
when it
system works
the
well.
system works well with them. But when it comes to birth center midwives or home birth midwives, that's when things get a little bit
Yeah, and I think it's
harder.
such a disservice that there is not this system that helps accommodate professionals in all spaces for the greater goal of, healthy outcomes for moms while respecting their birth options, right?
Mm-hmm,
Like
mm-hmm.
that's the whole thing that's missing. It's missing, and it's like it doesn't help anybody,
No, it
but it just
doesn't.
continues to foster this tone of, like you said, distrust and judgment, and it's just an uncomfortable space to be in
It is. It's
for
very
everybody.
uncomfortable for everyone, right? And um, one of the things that I've been watching with my residents, so there's been a new relationship that was established between the Atlanta Birth Center and Morehouse
Okay.
after the closure of
Of
AMC.
AMC. Mm-hmm.
And it's been interesting to watch my residents interact with the women who are having to be transferred from the birth center to the hospital, um,
Mm.
and really helping the residents reframe how they approach women who are in that kind of transitional space
Yes.
and trying to see both sides of the equation, right? There's the side of the equation where I've said to my resident, well, think about it this way. She had never planned on being here. She had planned on being at a birth center. The birth center rooms are so different. It's more conducive to having a child, right?
Mm-hmm.
Our rooms are not set up to having a child. They're set up to medicalize having a child, which is what we do. That's
That's the
that's who I
hospital
am, and
setting.
I'm fine with it. That's who
Right.
I am. That's part of my skill set, right?
Sure.
But trying to get my residents and my learners to understand, okay, you got to give this person the chance to switch her mindset because you're
Mm.
asking a lot in the moment. Um, and but also understanding where my residents and my fellow colleagues are coming because I've had this conversation with some of my midwifery friends, like, you call me when things are falling apart, so the patient is almost always angry at me.
Gotcha. Yes.
And
You
there a
walk into
lot
the
of that
fire.
a lot of that
Yeah, yeah,
that
yeah.
that discomfort in the conversation is, I never walk in when things are good. I walk in when things are falling apart and I have to pick
Mm.
up the pieces. It's the, postpartum hemorrhage that may not get taken, that may end up having to go to the operating room. It's the, all those
In the heightened
complications.
moment of some
Exactly.
very stressful situation.
Exactly. And so we don't get the chance to establish a rapport with the person because the person comes into our setting is already angry. Not
Mm-hmm.
necessarily angry at me.
At the
They're
right.
just angry that they lost this experience that they
Mm.
had planned on having.
Mm-hmm.
Um, they're angry because the people that they relate to, that they're comfortable with, are not there with them. They're angry because they're scared
Yes.
because of everything that they've heard or seen or read. And then, here
Right.
comes my resident or my fellow attending. Okay, your baby's not looking so good. We're going to have a C-section. See, I told you. That's what in the newspaper, that's all they do. But
Mm.
the whole reason you're here is unfortunately because that's what needs to happen. And so,
And so, how
it's
do you ease that?
that's
How
the
do you ease
problem.
that? How do you, because this is a highly emotional moment
It is.
for a mom, let's say transferring in from home birth or the birth center.
Mm-hmm.
It's not what they planned on. They're already angry and mad and upset for obvious reasons. But how does the communication remain effective between everyone involved? Because, like you said, lots of people coming in and out the room.
Mm-hmm.
Support persons are very protective and
Mm-hmm.
wanting to advocate for a client, for their
Mm-hmm.
family member.
Mm-hmm.
Like there's a lot to navigate there.
Mm-hmm.
So what happens? Like how do you, or how would you advise others, to like make communication more effective so that it's not a matter of you versus me, but a matter of mommy needs this and this is how we have to approach it.
Who? Uh,
Because it's like a lot.
I think in if I could imagine the best possible
Mm-hmm.
situation, it would start with the midwife and the provider having a relationship outside of the patient, right?
Right.
So that, for instance, with you, if I had a private practice, I'd be like, okay, here's my card, here's
Mm-hmm.
my pamphlet, here's my whatever. What can I do so that when when the women are coming to you, they know, okay, this is the person. If things go south, this is the person that's going to be on the other end. I think a lot of it for women is the unknown. I don't know you. I don't know your system. I don't know the
Absolutely.
hospital. I don't know you, and I'm scared, right? And so being able to have that relationship between providers before the transfer,
Yeah.
I think will make a big difference towards easing the patient's fears. It's like, okay, if Christine trusts her, then I can at least give her, like, I'm gonna give her a chance, and I think that part sometimes is missed because of the
And very
circumstances.
non-existent too.
Exactly. Um,
That's hard. That step one. If that was step one, how do we do that?
I mean, that's, to me,
Because
that's the first step.
I mean
And
that, like you said, that's truly ideal to
mhm,
have that relationship. But that is the reality. We know is the direct opposite, and
it
so
is.
that is what you're right. That does not help the transfer process, if
No,
you
it
will.
doesn't.
I try to do my best. Okay, I
Listen,
listen. When we have moms who transfer in, Dr. Didi, I'm like, here's the fax number, here's the prenatals, here's everything, here's the report.
it's
This is
so
what
funny
we've
that you
done.
said
Do do do
that.
do do, and
It's
it's
so
great.
funny that you
And then
said
it's
that.
like no one cares.
No, we do. Let me tell you, because I cannot remember. It was a few weeks ago. Somebody said,
Mm-hmm.
"Oh, this patient, she's a home birth," and Christine. I said, "Oh, this patient good. Don't worry about it. She got all her stuff done. Just."
All the stuff is in place,
I said,
honey.
"Everything is done." I was like, "I can vouch for them."
Now I can't be responsible for how they act, but you got what you need to
So,
take care of this
but it
patient.
makes a difference because when the residents were talking, I was like, no, you can I know this healthcare professional. Yes, she's a home birth midwife, but she has her whole system very well thought out. I was like, you can trust that the patient has been extremely well taken care of. Just focus on why she's here. You don't have to
Mm.
worry about what's on the back end because a lot of it, like I said again, for us physicians, we feel like we're holding the pot at the very end,
Understood.
right?
Yeah. A lot
Um,
has transpired before you've met the patient.
exactly.
Mm-hmm.
So that's part of
Sure.
the issue. The other part is really teaching, and I had to learn that myself. It's like, how do you walk in the room to talk to this person, and
Mm-hmm.
how do you give this person space to process everything,
Sure.
but also try to explain to them, okay, this is why I'm here. This is why you're here. This
Yeah.
is what we're going to do, but you have to give me a chance to do my part
Right.
because I do want what's best for you. And so, how do I walk in the room and convey that to her
Yeah.
and to whoever is in the room? And that's where the notion and the concept of respectful maternity care for me is rooted in that idea of being able to walk in there, acknowledge everyone in the room, acknowledge all
Mm.
the things that are in the room, like saying,
Yeah.
okay, I know this is not where you want it to be, but we will do our best by you. I think sometimes just that sentence makes a
Yes,
difference
it
because
does.
we walk in the room, my resident's like, but I want her to be well. And I say, yeah, but she doesn't know that that's what you want. So you have to verbalize that to her. You have to verbalize that to her partner, her doula, her mom, whoever's in there. You have to verbalize
This
that,
is so refreshing to talk to you about this because you are front line with up and coming physicians, right? Residents, if you will, people graduating to become obstetric doctors. And I feel like a huge part of that is missing where you have to just bring it back to basics. Like, how would you want people talking to you?
Mm-hmm.
Put yourself in this woman's shoes. Imagine what it feels like to be here, period. You know what I mean? Especially when you hear all of the maternal mortality rates and morbidity rates, and we're in Georgia and all the things. Like, you have to be respectful. And I feel like it will create a much more positive tone.
Absolutely.
We may not be able to change how she feels about being there, mommy, right? But at least she can say, well, everyone addressed me accurate, respectfully, addressed my spouse, respected my supportive team that I have with me. You know what I mean?
Absolutely.
And I just feel like that's so easy to do, but it's not always done.
I mean, you know how they say common sense is not common? So, I think one of the things that I had to do when I started looking to how do you teach respectful maternity care, like it's like it's not compassion, because I would say that most people who go into healthcare, not all, but most of us are compassionate.
Yes.
It takes some level of compassion to stay up for 24 hours laboring with
You're right. I don't think I'm that compassionate. I don't think I'm.
You know you are.
At 2 a.m.
You still there?
Oh.
So it takes time to it's trying to explain to people it's not about bias.
Sure.
It's not about compassion. It's about respect. People say, well, I did respect. I said, but when you walked in the room, did you say hi to the spouse? I know you said hi to the patient, but did you say hi to the spouse? Did you acknowledge this person was there? When you walked in the room, before you turned the lights on, did you say, hey, is it okay for me to turn the light on? Is it okay for me to pull the sheet? They're like, but I have to check her. I get it. But did you explain to her? And it's like changing how we're trained, because we've been doing the same thing for so long. So you're kind of changing some of that aspect of
but
care.
Also just bringing more humanity into the space. We are humans.
We are, but remember where we come from. Right?
How that's deep.
Remember where we come from. Like, I was rounding with the residents one time, and they said something to the effect of the patient had to be in the bed. I said, why she got to be in the bed? And they're like, what do you mean? I said, well, why does she have to be in the bed? Why is it that the first thing we do when the patient comes in, we have them undressed, we take their underwear off, we put them in the bed, and we strap them? It's like, to listen to the baby. I said, but you don't have to do all that to listen to the baby. I was like, think about where all of this comes from. How did they labor slaves? And if you go back and you take the time to sit in the fact that, we come from a really dark background, but this is our chance to change it, right? We can change the course of how we practice obstetrics. Like, we're really good at what we do. I would say all my residents will make amazing, phenomenal OBs. But it's taking the time to teach them those other skills that are not necessarily soft skills, but that will allow them to be able to walk in a room and establish a relationship with a patient. And that's what I like about being a hospitalist, because they don't know me, I don't know them, I may never see them again, but in that moment, I have to earn their trust so I can be there for them. And that means I have to walk in there and not bring whatever it is that I'm carrying with me in that room. I have to make grace for the patient, even if she hasn't been to prenatal care. That used to irk me. But then, I talked to a patient and she said, I was getting prenatal care. I didn't like the way I was being treated. So I stopped going. I was like, okay, that makes sense. I can't be mad at you about it. Right. And so it's like really being able to leave everything that you take for granted outside of the room and just be open. And it takes time to teach those skills. So
interesting.
I
just need you on call every single day.
No.
Can we just
I got
clone
my babies.
You? Can we just
I got my
clone
babies.
you so bad? Dr. Dee Dee is who we need. Okay, So let's just shift the conversation,
Mm-hmm.
piggybacking off of the fears, right? So black women are afraid.
Yes.
Black women who call me for home birth services, even when they're not candidates. I'm afraid to go in there. I don't want to go in there. I'm going to die. You know, everyone's heard this. It's been pounded in our heads, right?
Mm-hmm.
What is your advice to women who are really, really afraid
Mm-hmm.
to enter the hospital space?
That's a tough one to answer. One of my best friends that I absolutely love is a doula.
Mm-hmm.
And we always have these deep conversations. We're like, we should tape our conversations because we have
Mm-hmm.
these really deep conversations, and we were talking about that. Um, there is a legitimate issue, right? Black women, women of color, are not treated
Absolutely.
as humanely as they should be. They're not respected. Their voice is not heard. So
Mm-hmm.
those statistics are true statistics.
Sure.
But those statistics are not every story, right? And so we're not talking about women who are successful in their pregnancy. We're not talking about the resiliency of Black women who,
Mm.
like, I know witch doctors at AMC tonight, so I'm gonna go get my ultrasound tonight because I
Right.
know,
Mm-hmm.
this doctor gonna be there. Like, I remember at AMC, a patient just showed up. We're like, how do you just show up for your C-section? It's like, oh, my last baby, Dr. So-and-so delivered my last baby.
She's
So I
here
know
today, and this
he
is
gonna
our.
take care of me. So I'm
I
coming
know
back for
that's
him to
right.
take care of me. Like, we are resilient, right?
Mm-hmm.
And
Mm-hmm.
we are really smart. And so, I think we need to start talking about the stories of successful pregnancies, of successful outcomes. We need to start talking about, you know, how beautiful it is to be a Black mom. Like, Black motherhood is beautiful. I
Yes.
fell in love with that. That's why I went into obstetrics. Like, it was
Mm-hmm.
fascinating to me. It was just such a beautiful thing. And so, yes, there are the bad stuff, but we also have to start talking a little bit more about the opposite side of the
I agree
coin.
with
And I
that.
think it will make a difference to allay some of the fears because we've been talking about the bad so much. It's
Sure.
like every conference you go to, it's like Black women are dying, blah 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 blah, and and you think that every Black woman who has a baby
You would
is
think.
dying, but
Mm-hmm.
that's not true.
Okay.
It's a high percentage.
Yes,
It's an unusually high percentage. Is an unfairly high percentage,
it is.
but it's still just a percentage. The majority of us have fairly decent pregnancies, other than the aches and pains and,
Mm-hmm.
the annoying mother in law or,
Yes.
the people in our family who want to come and tell you what to do. We have fairly good pregnancies, we have good outcomes. We have good midwives, we have good physicians, we
Mm-hmm.
have good doulas who help us navigate it, and we have successful outcome. But we're not talking about that. Um,
That's true.
and I think it's important for the women in our community to hear that, she was pregnant, she had preeclampsia, but her doctor and her midwife or whoever was taking care of her was there with her every step of the way, and she went home with a healthy baby,
Mm-hmm.
and this is how they took care of her. So I think there is that part of it. And then the other part is ask questions.
Mm.
You know, just like, again, one of your guests said, interview your physician. Like, we interview I'm not going to go to any hairdresser. I'm going to be like, okay, so, did you go to her and did you like her? And then
Right.
I'm going to find out who's been to that person and how
Correct.
many people have been to that hairdresser before I book an appointment. Why don't we do the
Mm.
same thing with our providers? Ask questions,
Mm-hmm.
you know?
And so what if people are in their feelings about it, right?
That's their problem.
That's their
That's not your
problem.
problem. When I
Mm-hmm.
was in private practice, I always told patients, go get a second opinion. They're like, no, I agree. No, go get a second opinion because how I see it may not be how they see it. It will
Mm-hmm.
not hurt my feelings if you go to that person. I want you to go where you feel safe, that what you need is going to be delivered to you the way it needs to be delivered to you. And if I'm not that person, it's okay. I'm not that person. But we have to start asking questions. We have to start interviewing our providers. I told a friend of mine that the other day. She was dealing with some infertility issues, and now
Mm-hmm.
she's pregnant. And
Mm.
I said, well, who's your doctor? She said, well, I just picked a GYN for infertility. I said, well, do you like your GYN? Well, no, but I'm already there. I said, so what? You don't
Because
have to
every
stay there.
every
If
time,
you're not happy, then
yeah.
every time your physician says to do something, even if it's the right thing, you're going to question it because you are not comfortable. it doesn't mean that that provider is a bad provider. It just means that that provider is not the right provider for you.
Especially if they don't like you questioning, right?
Exactly.
Because there's a lot of that,
Absolutely. You
right?
should
You
always
ask
be
a
suspicious.
question and you just for true knowledge because you don't know something
Hmm.
and they are in their feelings. Oh, well, go and get somebody else because this is how we do it. And if that's the case, that's fine. You know, that's your ticket, your reason to leave. But there is a lot of discomfort around people asking questions about their own health care, which is crazy.
It, again, it's rooted in history.
Wow.
We never asked
It just
questions before.
comes right back to that.
It does. We
That's
never
just the bottom
asked
line. That's
questions.
the bottom line.
And some of it in the Southeast, I remember when I first, because I did my training in New York. So I did my
Okay.
residency in New York, and then I came down south. And I remember thinking, my patients in New York, if I said you need a hysterectomy, they'd be like, okay, how are you going to do it? How many have you done? Et cetera, et cetera.
Okay.
And then they
At
would
you.
come for me. And I had to be able to answer the questions
Yeah.
versus I came down south and I'd be like, oh, you need a hysterectomy? Okay, so when do I have one? And I'm like, don't you have any questions? Don't
Got
you
it.
want to know about alternatives? So if you really think about our history here in the South, we're not used to questioning. Think about it. We're not used to questioning, right?
Mm.
So when we were having babies, we're not used to questioning. When they said you're not feeling pain, we're like, okay, well, I guess I must not be feeling pain. Even if I'm dying, I must not be feeling anything because you're telling me that I'm not feeling anything. We're not used to questioning down here. And we have to start questioning. We have to start asking questions. And then the flip side of it is, as providers, we have to start learning to listen to the question that is not an attack, it's a genuine, I'm scared. Can you please answer this for me?
Right.
Right.
Right. Right.
Um,
Receiving it.
exactly. But full transparency, it's been a journey for me to get to a point where when patients ask questions, I'm like, oh, okay, sure. What do you want to know? Or sometimes I'll be in there and I'll say to the patient, okay, this is what's going to happen, but if there's an emergency, I may not have a chance to answer your question.
Got it.
So please ask me the questions now, because if something goes wrong, I will try to
And
tell
this
you
is a
what we have to
relationship
do.
being built.
Exactly.
Right.
But I may not have the chance to sit and explain it all to you
That's
because I
true.
have to put your baby's health
Yeah.
ahead
And
of
I do the
all
same in
of that,
home birth. You
right?
know, they're like, how do you handle complications? And I'm like, well, I can run down the list of things I've experienced in the home setting, but when it's happening,
Hmm.
there may not be a lot of time to have a conversation about what needs to happen ASAP, you
Absolutely.
know? So that goes back to just communicating,
Absolutely.
and you can foster a relationship by asking questions and engaging the provider.
Absolutely.
If the provider's not receptive to the conversation,
That's
then
not your
that needs to
provider.
be that's not your provider. But
That's
if
not
it
your
is,
provider.
then they know, I mean, okay, we're having conversations around this woman's care.
Hmm.
She wants to know things. She has questions. She wants to make sure she's making the right decision. And I feel like, why can't we just
Because it's hard. In the moment, it's hard. If you think about how busy you are in
yeah.
in the hospital setting, because that's the other thing too,
Yeah.
is that we take care of the patients who are generally the unhealthiest.
Mhm. Mhm.
And so when you think about the acuity of the service that we provide,
Yes.
it's like I just want to be able to go in there and say, okay, this is what needs to happen.
Right.
And so when you're asking me to stop and explain, it's like I
Sure.
have to slow down everything when I'm thinking about you, and then I'm thinking about the woman down the
Right.
hall,
Right.
and
Right.
then I'm thinking about the patient down the hall whose baby doesn't look good, and I'm gonna have to go do a
Mhm.
C-section, but you're asking me to stop and explain to you why you have to be on Pitocin. You know what I mean? And
I
so
do.
it's like, again, it goes back to us retraining ourselves as providers to really step back and think, okay, how, if I was in the bad, how would I want somebody to walk in here and talk to me?
And then the system isn't conducive to that type of care.
It's not.
It's not set up for time to talk, like extensive extra time because you
True.
are managing more
We do.
than
We
one
do.
mom.
But I think there is value in modifying the system.
Mm-hmm.
If you can't change it all the way, there is value in
Finding a
creating
way.
the time. Like
Mm-hmm.
one of my best residents, she'll be like, okay, listen, I got to go talk to somebody. I'm going to be back. When I come back, I'm going
Right.
to sit with you. And
Mm-hmm.
she will go do what she needs to do. And then she'll come back and she'll sit with the patient. She'll have a whole conversation with the patient. And I think part of what makes her so successful when she interacts with patients is that she follows through. She's like, I heard
Mm.
you. I just can't do this right
Right now.
now, but I'm gonna come back and we're gonna do this.
And on the flip
Right?
side, on the client side, in that same situation, hey, can I get 10 minutes to think about that? Or can you come circle back around because I do
Mhm.
have some questions? Like both parties can make a way.
Absolutely.
Because you have to.
Absolutely.
You have to.
So,
You
yes.
need to come back. Are you going to come back and talk to me?
I don't know. Are you gonna trap me?
This is great. This is a great interview.
You and I always do good.
We do.
We always do good. All we need is a little food, and then
That's
this
it.
will
And
be
some wine,
perfect.
and we're good. We're wine and cheese girls. Okay, Dr. Dee, can you tell the people how can they find you?
They can't.
Why? We
Because
want
I'm a
to.
hospitalist.
We want where? Can we say where?
No.
We can't say. I'll just text her and say where you at, and that's where we're coming. Thank you for coming.
Thank you for having me.
This was fun.
I always learn a lot when you and I talk. It's
Same. I learned a lot from you. This was great.
It was.
This was really eye-opening.
But see, that's the
But
thing.
I
We
wanted
just
to
need
put.
to do more of this.
We
you
will.
know?
And I feel like I wanted you to be here because, when people think of like physicians and doctors, it's just a role
Mhm.
versus a human
Mhm.
side, right? And so you were the perfect human to come in your profession, to come and talk to us about all of this
Mhm.
because, we're friends.
We are.
But you have a very balanced, centered, respectful way of your perspective on everything just makes it more receivable, like more receptive. You know what I'm saying? The information that you share.
But I think,
It makes it more receptive because we don't get this opportunity to really talk
but
to like a doctor.
it's like it's like you had your journey because you weren't always a home birth midwife.
No, right.
And it's been the same for me. It's like
Yeah.
growing and understanding and really thinking about, like, I fell in love with OB, but now it's like, how do I make it a more humane thing? Like, how do I become more humanistic in how I take care of people, or how I bring the things to the table, and how we take care of each other, right? Like, coming away from I'm going to take care of you to we're going to take care of you. So what do I need to hear from you? And then can you hear me? And then we can do this together. And I think midwives do that so much better than physicians do. And we have to learn this, so.
Well, I appreciate you.
I appreciate you.
Oh my gosh.
We're just missing the other midwives and the doulas, and this would be perfect.
Yes, absolutely. This is the Birth Exchange podcast. You're welcome. Thanks for coming, girl. I was nervous. Oh my God. Dr. St. Louis.
I don't know why you were nervous.
This is the Birth Exchange podcast, and we've learned a lot from Dr. Dee today. And basically, she says to stand in your resilience because you are strong women who can take care of your bodies. You know what's best for your bodies. And we also learned a really good history lesson here as to why the tone of care is what it is today, especially in Georgia. So we thank you so much for coming to join us today. Like, subscribe, share, follow, and all the things. And we'll see you on the next episode.